Today, we are lucky to have Dr. Paolo Bolognese joining us and speaking about Chiari malformations. He is director of the Chiari and Ehlers-Danlos Center at Mount Sinai, South Nassau, and a world-recognized expert in Chiari malformations. So thank you very much, Dr. Bolognese. Looking forward to your talk.
Thank you. I'm going to share my screen. Tell me if you can see it. All good?
Looks good.
Very good. Thank you. Dr. Batterson, dear colleagues, it's an honor to be here. Just to preface, this presentation is aimed to the residents, so it's going to be a little bit on the basic side. So we're going to start with some history. The first mention of a picture which was very resembling of Chiari malformation in syringomyelia dates back to several centuries ago in an ancient Chinese text. Pay attention to the guy on the right because he is going to come back in this presentation. Hans Chiari was a pathologist. He was part of the Austro-Hungarian Empire. He was chairman of pathology at Prague. And while he was working on autopsies of patients affected by tuberculosis and typhoid fever, he started seeing a recurrent finding, which was that one of herniation of the tonsils, but cerebellar tonsils. But then he started seeing the same finding in people who did not have these problems. And he started seeing different anatomical variations. And from a pathological standpoint, he divided these 4 recurrent patterns in 4 Chiari malformations. Incidentally, these Chiari malformations have nothing to do with each other from a pathophysiological standpoint. 50 years later, in Europe and the United States, the first surgical pioneers started dealing with this disease, and they started, getting their feet in the water. And this is the first classical article by Gardner. The results were not great. The outcomes were not great. The complication rate was very high, but still, that was a beginning. Years later, first with the CAT scan and then with the MRI, the incidence of Chiari malformation started going up. It was no longer perceived as a rare disorder. And the 5mm rule was introduced by this article by Barkovich on the American Journal of Neuroradiology. 5mm rule for the neophytes means that everything beyond 5mm from the foramen magnum is considered Chiari malformation, and anything short than that is not. The article had many methodological flaws, but that was the rule of the land from that point on for the years to come, for a number of years. The first game changer in the management of this disorder was a British, very brilliant neurosurgeon called Bernard Williams. He started developing a focus on this disorder, and he started having a systematic approach, both from the understanding, the clinical analysis, and mainly on the surgical management. He started accumulating cases, and by the time of his untimely death, he was stuck in a dilemma. Do I leave the dura open, like I would do for any kind of cerebellar tumor at that point in time, which was the late 80s, or I do a duroplasty and then I get stuck with cerebrospinal fluid leakages? By the time of his death, which was after a motorcycle accident, he hadn't solved this dilemma. And his efforts were supported emotionally and financially by one of his patients. A few years, practically with an overlap towards the end of the life of Williams, Dr. Batzer from UCLA took the baton and perfected the duroplasty technique and brought down the incidence of pseudomeningocele by a factor of 5. He was, since he started doing the surgeries over and over, he brought this surgery to a very high level of reliability, and that became the workhorse. He's also venturing in the systematic use of shrinking the tonsils with bipolar coagulation. From that point on, Chiari malformation became the playground of the elite with, all-star lineup from Ed Benzel from the Cleveland Clinic, Dr. Menezes from the University of Iowa, Dr. Michael Scott from the Brigham, Bart Green, Miami, Jeffrey Oakes in Alabama, and Dr. Oldfield from NIH. Most of the Chiari malformation, a large chunk of the Chiari malformation cases of this decade, for about 15 years, were concentrated in a small number of centers. The next game changer was Thomas Millerad. Thomas Millerad was the chairman in Brooklyn, and he was historically an expert in the field of the field of hydrocephalus. And for him, it was a natural step to venture into syringomyelia, because syringomyelia, in poor terms, is just the hydrocephalus of the spinal cord. So he started seeing the limitations of what was the understanding back then, and he developed a surgical approach and a experimental model, which is still the gold standard now, as perfected by Dr. Studley from the Macquarie University in Sydney. Sidestepping from syringomyelia to Chiari malformation was a natural thing. 75% of the syringomyelia cases are caused by Chiari malformation. And after concentrating for the age an enormous amount of clinical experience, he wrote this article. This article is still the most quoted article in the history of Chiari malformation literature. And it's called Chiari Redefined because he redefined the entire understanding of the disease. These are some of the points. He described the epidemiology, set in stone. All these things are still valid now. He described the difference between adult and pediatric. He detected the trauma was a number of triggers, including trauma for the symptomatic conversion. He expanded the concept of the clinical presentation from the simple tossive headache or headache in the back of the skull to a much larger cohort of symptoms that to that point had been ignored. He also systematically described a number of additional MRI findings which were recurrent with this disease. He went in depth with morphometric analysis and introduced the concept of Chiari as a mesenchymal disorder causing a posterior fossa, small posterior fossa squeezing the tonsils out. He also picked on the psychological profile, the pedigree with inheritance patterns of a number of patients, and mainly exposed the flaws of the 5mm rule on a large scale of patients. Again, the 5mm rule was born from a radiological standpoint. They see pictures, they don't see patients. He was seeing both. The concept was, the approach was more and more multidisciplinary. Dr. Nishikawa was the main guy for morphometrics at that time. He spent 6 years with us. And this is the battery of all the morphometric analysis that he was performing on both for research, clinical research purposes, and on a daily basis on all the patients passing by the center. Again, multidisciplinary. Dr. Kula was our fine neurologist. Dr. Marcy Spear from Duke ventured into the analysis of the genetics of Chiari, which is present in about 28 to 30% of these patients. Once you start seeing around and snooping into familial distributions and cohort. And Dr. Franco Mano from NIH back then was in charge of Department of Aging. She helped us venturing in the field of a connection between Chiari malformation and connective tissue disorders. Chiari Institute was a natural next step. If you build it, they will come. And it was done capitalizing on that initial experience. It went on from 2001 to 2015, was multidisciplinary center with many disciplines attached. We were a team of 3 neurosurgeons, including Dr. Rumprapult, And we had a very high clinical and surgical volume with a very wide geographical net. Obviously, when you have a concentration in time and space, you have the luxury of having a accelerated learning process. You can test multiple things day by day instead of doing one case now and then testing the next thing, the following month. The combination of high volume and full immersion allowed us to see patterns from a specific vantage point, which was the high volume. So we can recognize pattern, we could recognize pattern ahead of the time. In the OR, we tested every single variation of the surgery, from the most conservative to the most aggressive. And every day we added and nuances and we pushed every single feature of it. And we became very aggressive with tonsil manipulation. We started with extradural technique. We ended up being very aggressive inside. We systematically use intraoperative monitoring, and as you play more and more, your complication rate goes down, is an obvious statement. And our pseudomeningocele incidence, cerebrospinal fluid leakages confined within the skin and muscles, went from 18% to 0.3%, just a matter of practice. Color Doppler was very important. We're going to see in one of the next slides. And we started investigating on the surgical failures which were floating around. And the next natural move was to redo surgeries to correct these problem patients who were floating. And then we started seeing more and more comorbidities. Color Doppler ultrasound was important for two reasons. It gave us advanced reconnaissance before before opening the door, but is the door opening in the bonework fitting what we're going to do inside, or we're going to be too tight, too wide. So we started tailoring our procedure according to this feedback. It was like having a drone before going on the battlefield. But the most important thing for us was that after closing the door at the end of the case, we were able to grade ourselves for the next time over, with not only with assessing the volume of how much we had corrected the tonsillar herniation, but mainly to see the patterns of cerebrospinal fluid flow with jets at different patterns during the surgery, immediately after opening the door, so we could see the jets of CSF coming from Bushka, coming from Magenti, etc. It was a very good and accelerated learning process. Then we started seeing other things. Tonsil herniation, as we encounter, can be caused by other things. We have tumors, lumbar drains, etc., which can cause all this. And so we adapted. We applied the concept of morphometrics to a very large database of patients that we had, Chiari and not. And we came out with different patterns, which were morphometric bases. Morphometric means there are specific anatomical features of the posterior fossa, foramen magnum, etc., which come with each one. So each one had their different profile. If this table is a bit confusing, this is the way it can be simplified. The tonsils can be pushed, pulled, or squeezed out of the skull, or it can simply dangle because the tissue is loose, like in certain connective tissue disorders. What's the meaning? The meaning is that tonsil herniation is not tantamount or a synonym to Chiari malformation. It should just be restricted when the tonsils are squeezed out of the skull by a volumetrically small posterior fossa due to a mesenchymal disorder. The concept of Chiari malformation versus anomaly was introduced relatively recently and expresses the fact that if something often is asymptomatic or becomes asymptomatic later in life, and not 100% of the time, maybe it's an anomaly more than a malformation. During the following years, other authors introduced this other concept, mostly from University of Alabama, and about 0, 0.5, 1.5. These are just variations on the theme of the 5 millimeter rule is not really exact. So let's try to make sub cohorts. This was for some neurosurgeons, not on the, some basic hospital neurosurgeon. This was a little bit more confusing than clarifying. The classification of Chiari at this point in time has shifted from Hans Chiari giving us his pathological point of view to the radiological features of the mid-80s with MRI, and now with pathophysiologic mechanisms driving the classification. But now what about surgeries? We're surgeons. So we came up with our own surgical classification, not so much of the Chiari, but surgical classification of things that we stumble on as surgeons. So simple Chiari is Chiari by itself. Chiari redux is a Chiari malformation surgical case that is floating around, is not really great about outcome, and is being held back by a complication, suboptimal technique, somebody who doesn't punch harder enough, or something else, like we're going to see later, is going to be mostly comorbidities, or Chiari plus. Chiari plus is a virgin case that not only has Chiari, but is an associated problem with it. And the associated problem can be a comorbidity or a congenital malformation, which is in addition to that. So this is a list of comorbidities. This is just partial, it's still ongoing, it's still growing as it is. And at the very top, which is improper, and that's why it's in italics, is the syringomegaly. Syringomegaly is not a comorbidity. Syringomegaly is an effect of Chiari malformation. 50% of Chiari malformations have a syringomegalia cavity, and syringomegalia cavity is hydrocephalus, the smaller core, because it dilates a pre-existing very small cavity. But again, enough with the syrinx. This is the list of the comorbidities, the Parkinson crime, which if they were the horsemen of the apocalypse, that if they come along with Chiari and they have a very strong role and they hit the patient very hard, if you ignore them, your outcome of doing a standard Chiari surgery is going to be held back. Again, comorbidities. When we wrote these first two articles during the first decade of the centuries, they were received with skepticism. And it was a natural thing. We were sitting on a vintage point out of thousands and thousands of patients. So for us, it was easier to see a pattern that others who were not blind could just not see from their amount of patients. But years later, everybody caught up. First were some groups, and then became more and more general. Obviously, there is a difference between thing percolating to an expert level and thing percolating on a day by day activity of any hospital and any practitioner. But any one of the leading experts now agree to all the things I have listed so far, which are from the Chiari Redefined concepts to the concept of comorbidities, and all these ideas are strongly permeating the common data elements of the NIH, which is practically how you should approach practically the lingo, the glossary that you should use every time you approach Chiari malformation in a clinical scientific project. We're midway, so this is just some pearl. Chiari malformation is a focal form of craniosynostosis. 28% of the surgical cases that go to surgery have trauma as the trigger for their symptomatic conversion. They were not symptomatic, or they were mildly symptomatic before them. And most of the Chiari patients on the face of the earth, if we did an autopsy or an MRI on everybody, are oligo or asymptomatic. Now we go to surgery. The surgical goals are obvious. Tonsils are in a place where they don't belong. They create the ruckus, they push things around, they block the flow. We have to restore the balance to the force, so let's not make it that complicated. I love the wit of Dr. Berglund. Was a genius playing as a fool. He was the first recipient of the Van Wegener Fellowship. So, but we have decisions. So what we're going to do, we're going to cut some slack around the tonsils, or we're going to hit them hard, because those are the responsibles for the tonsil herniation, responsible for the problem. And it's a space game. So we are going to buy space outside of the dura towards the outside at the expense of the bone, or towards the inside at the expense of the tonsils, which are the problem. And at that point, you have to pick your weapon, which is also your poison. So with extradural techniques, you have reliable outcomes. They're not phenomenal, but it's a reliable product, and you have lower risks of messing with cerebrospinal fluid leakages and complications. On the other end, the intradural techniques have better outcomes, but you have a higher risk of complications. And when we say complications, the paradigm, the big problem, the dragon that you have to fight, is the cerebrospinal fluid leakage, which can come out of the skin, the fistula, or can be confined within the soft tissue outside of the dura. It's called pseudomeningocele. There are many, that's one of the many meta-analyses out there. Everybody agrees about the concept. Less, extradural, you don't hit so hard, but you have a lower risk, and vice versa. So before you guys, as residents, make your own decision about what strategy you want to apply, these are the building blocks of any kind of surgery. And you can confine yourself to the very first ones, or you can go for the whole Chinese menu. The dural scoring is, for example, what was presented in a case 2 or 3 months ago. Dural scoring is a Japanese technique from the early 90s, in which you just cut the outer part of the dura and you allow the dura to expand a little bit. You buy some space. Craniectomy, you just cut some bone where the problem is. It's a volumetrically small posterior fossa. It is like you open the belt and the zipper at the end of Thanksgiving dinner. The size and the shape changes from patient to patient, from the doctor to doctor, to the point that if I see a 3D CT, very often I can recognize who the doctor who did it. The parts of the skull above the cerebellar hemispheres tend to be very thin, sometimes paper thin. The opening the dura is done in a Y fashion, like you've seen on the left. And the duroplasty can come with different materials, different stitch patterns. All the heavy hitters internationally, they use the same material, which is the autologous pericranium, which takes an art to harvest properly. But the problems is 6 o'clock, 10 o'clock, 2 o'clock. These are the places where the vast majority of cerebrospinal fluid leakages happen. Now, at 6 o'clock, you can be saved by something called the Canadian overstitching, but at 2 and 10, the problem is that the dura is very thin because of Chiari malformation, pushing from the expansion, it's not expansion, the beating of the cerebellum against the skull, the Count of Monte Cristo dilemma pattern. Now, once you open the dura, you find a wide variety of presentation, the anatomical presentation of the tonsils can be wide, fat, but whenever you attack them, you have to know where the pica is, where the arachnoid bands are. The same that Dr. Betos said before, know where your arteries are, know where your delicate things you want to do before you go aggressive. And you can shrink them, you can do a sapia resection, same thing that you saw before with the debulking of the tumor. And but here the main message is the imperforated balum medullaris. Imperforated balum is like a piece of saran wrap, congenital, very often found in people with Chiari malformation, which is covering the entire foramen magendae. So if that happens, cerebrospinal fluid cannot come out of there, and no matter what you do to the tonsils. And you're never going to know you have an imperforated velum unless you go and look at it. So, and you cannot see it if they leave the door open, even with the ultrasound. Now, On the side of the brainstem, where often the tonsils are stuck, the place that Dr. Mirat was defining as the gutter. Lot of structures going there, 11, the origin, the pica, etc. It's very busy, and not so many people go there. And if the tonsils material is still stuck there, the lateral part of the tonsil, all these things are not going to catch a break. Cranioplasty is used by some, has a role of itself for selected cases. Here, the point is you can make it as easy or as bespoke and sophisticated as you want. Concept number one, if you put a cranioplasty, don't make the mistake or make it too tight. Otherwise, you're going to crack the skull open because the skull is too tight. And then you put the cranioplasty and you make it tight again. Assumption number one, all types of Chiari surgery are equivalent, all variations of Chiari surgery. And that's obviously false, but how you prove it. If you ask a patient or another patient, how's your pain before and after, especially if you ask an Italian, because Italians always, the pain is horrible. I'm Italian, I can say that. You cannot compare what's objective, but you can compare how a syringomelia deflates after a type of surgery versus another one. And the percentages down there are the national average for the top centers. Extradural techniques do deflate the syrinx, but not to a degree and with an incidence which is comparable to the more aggressive techniques that again have a higher incidence of complications. Assumption number two, all surgeons are equivalent, obviously is false, but because there are different things which make you different, temperament, every surgeon is stuck between these two polar opposites of being a chicken or being a cowboy. You don't want to be either. The skill set, obviously, we're far away from being a Chevy Chase, but in the field of Chiari, what counts the most is the experience. And this came out the first time in earnest at a conference 2016, which was done here in Long Island. There were 85 participants, multidisciplinary from 5 continents, and 63 leading experts were polled about what do you do, what's your profile, what you do in the surgery, et cetera. This poll generated 2 articles which are published on World Neurosurgery. Collective experience was 15,000 surgical cases. Now, 8 surgeons were responsible for more than half, but what we found was that the incidence of pseudomeningocele was going down as the experience of every surgeon was going up. So somebody would say, oh, wait a second. So, but if the top neurosurgeons just do an extradural technique, they're never going to open the door and they're never going to have a leakage. So, you're tricking us. But the analysis was showing the total opposite. All the guys who were having more successful cases, not only they were opening the dura, but they were having the more aggressive versions of the Chiari surgery as their workhorse, and they were having a low pseudomeningocele rate. So putting a line in the sand, 600 was the magic number. Above 600, the incidence of complications was actually going down on par with a technique in which you do not open the dura, and you were having the luxury of both. You were having the luxury of having better outcomes, hitting the target harder, and you were having a complication rate like you were never opening the dura. Best of both worlds. Above 1,000 cases, actually the complication rate was further going down by another factor of 10. This is the club of 600 back in 2016. The people, 5 people on the left, they were between 600 and 900 cases. The 3 people on the right, they were way above 1,000. Problem, 6 out of 8, they're no longer practicing. Only 2 are still practicing. And from number 2, the people who are coming up, the young people, are going to be kind of running against the wind because there has been a wide proliferation of Chiari centers in the United States. And so it's going to be difficult for a few centers to accumulate a lot of experience. This is the guy I told you to pay attention in the beginning. Now the game changer, Dr. Yong Liu from Beijing. he had the brilliant idea. I'm not going to open the dura with a Y fashion. I'm going to open it as a vertical, small incision in the middle where the dura is the thickest. So I'm not going to have the 10 o'clock and 2 o'clock problem. And through that, I'm going to go hard on the tonsils. It was a great idea. Um, and the incision that he was having was very, very small, 1.5 centimeters. And through that, he was pulverizing the tonsils with the subpeel approach. So we met. He came here, I went there. We came up with two different versions of the same surgery, which means small bone work, just shave a little bit of the top of C1, vertical incision, and then you go bananas on the tonsils inside. The concept of peer resection dates back years before, and it was made reliable by Dr. Rosman. But doing it the way that you was doing is the equivalent of changing the carburetor on a Dodge Charger by after opening the hood just by a few inches. His version is crazy in terms of skills. This is what you can get with that approach. And the tonsils on the left is before the surgery, tonsils on the right is after. The correction of the retroflexodontia was done because at the same time I did the craniocervical fusion with condylar screws. So that's why the picture all the way to the right is funny looking because the screws are 0, 1, and 2. These are the statistics. His series was enormous, more than 1,500 cases of that technique alone. Right now is cruising around 3,000 cases. I had a very late start. And the complication rate that we had was extremely small, considering how aggressive was the surgery. Surgical failures practically can be simplified, and I'm almost done. Please tries to go. Is okay. Did we have a complication? So did we mess up? Second, did we not do enough? Number three, were we wrong about diagnosing Chiari, or while the symptoms were coming from somewhere else? Or number four, there is something else that we missed in terms of one or more comorbidities, which are partners in crime. And these are the take-home lessons. Every single type of Chiari surgery helps. I'm just going to read pedestrian. More aggressive type tend to help more, but they're more risky. And if something does not work enough, look if something more aggressive does apply in terms of surgical technique, or can be done by you, or you have to bump it up to somewhere else, to somebody else more experienced. And if it is going to make a difference, and if the risk benefits ratio makes sense. There is no ideal Chiari 1 surgical approach which can or should be done by every surgeon. I started the MIST technique after I had an experience of about 1,000 cases under my belt. Had I started the first day, the patients would not have left the room. Do what you're comfortable doing safely at that point of your career development. And if you have a focus in the disease, challenge yourself gradually and within your limit of your comfort zone, and then you try to level up. So the cerebellar tonsils actually, they do have a physiological role, but now I'm 2 minutes up, so I'm going to leave it. So I want to take a minute just to say that I'm very honored to be here. And every time that I participate in grand rounds, even when it's given by residents or students, I realize how ignorant I am every day. Thank you.
Thank you, Paolo. You should, because people don't know who Dr. Fasano was. Maybe
Dr. Fasano was my first mentor, and he was the chairman of the Department of Neurosurgery in Torino, which is my hometown. And Dr. Germano was ahead of me in the program, and before she moved to the United States and went to the West Coast. And every time that Dr. Fasano was talking about Isabella, his lights were his eyes were lighting up, and he was putting me down at the same time.
Yeah, I don't think that people realized at the beginning that Dr. Bolognese is also from Torino, like Dr. Germano, and came up through a really outstanding clinical program there that has produced a number of leaders throughout Italy, and continues as an excellent clinical and research center. I really
Yes.
enjoyed that, Paolo.
Thank you very much.
We got Sadi, I think Sadi's here, who treats a lot of these cases. Sadi, do you have any thoughts or comments?
Yeah, thanks, JB. And a great presentation, Dr. Bolognese. Thank you so much for the historical perspective. You know, I had trained in Seattle and saw Rich Ellenbogen do it his way, and I saw the folks in London do it their way. And I came to New York and was very impressed by Neil Feldstein's approach, which was to keep it very simple in a lot of kids and get really good results with a non-dural opening approach where indicated. As you're pointed out, there's a lot that comes in with experience and perspective, especially knowing when to open the dura and what to do in those cases. And here I still keep it simple with just a mandate to be attentive to detail with everything you're doing when you're there, get in and get out safely. And again, keep it simple. I just think that was a great presentation, and there's a lot to be learned from this one entity in neurosurgery as a model for everything else that we do. Thank you.
Okay.
Yeah, me too. I would just echo everything that was said. Really nice presentation.
Thank you.
Should we move on to Dr.
Okay.
Rappaport?
Next up, we've got Dr. Benjamin Rappaport. Somebody everyone in the